This is around 60-year-old female. So she has come with an history of jaundice. If you can see, like she has jaundice, discolorized, yellowish discoloration of the skin. And this is the liver. This is the ultrasound scan. When we see ultrasound scan, this is the liver. Lot of biliary radicals dilatation, gross. And you can see here, this is an hepatic artery. And this is a dilated biliary radicals. Whatever black we are seeing, so that is all biliary radicals. When we trace the CBD, we are not able to see the common bile duct, and we can appreciate a mass. So that mass is possibly a cholangiocarcinoma, which may be obstructing up to the confluence. These are the right lobe ducts dilatation, very gross, and these are the left lobe. And when we can see, confluence is partially seen, but CBD is not seen. That means there is a big mass sitting in the hilum of the liver. So now the plan is to relieve the jaundice of the patient first. What we should do? We can do, this is a cath lab, we are doing a percutaneous biliary drainage procedure. This is the epigastric region. We are planning to puncture the left lobe of liver, biliary radical dilatation, and then we will try to internalize the tip of the catheter into the second part of duodenum and then drain out the distended biliary radicals so that the complete relief of jaundice will be there. Let's go for the drainage procedure. This is called percutaneous transhepatic biliary drainage, PTBD, in a simplified manner. Can I get a smaller gauge? With a smaller is to reduce the pain for her. So now I am puncturing under ultrasound guidance. सन्न सूजी में छोटा सा इंजेक्शन देता है. So under the ultrasound guidance, I am puncturing the skin, subcutaneous tissue, and liver parenchyma there. So usually you can see, appreciate there, some amount of fluid there. So that is the one. Right. Take the biliary set. PTBD set. Can someone open? You want? Darud hai? Nahi na? Very good. No pain. Okay. Chiba needle. So advantage of this is since it is a very gross dilatation, there is no need for the smaller needle to puncture and exchange with a bigger sized catheter. So we can directly put the Chiba needle into the biliary radical and then just opacify by doing cholangiogram, and then you can take directly the wire. So now, so accurately we have to puncture the biliary radicals. See, that is the needle. Can you see this? I'll show this with a magnification by increasing the depth. Okay. This is a needle here. So we need little cranial position. I can just turn, because this is a stiff needle. I can turn around whatever way I want. See, can you appreciate that? See here, I am wobbling the needle. So now I am puncturing this is a biliary radical. So after puncturing that, how you will confirm it's a bile or not? You should get a honey colored. If it is non-infected, you will get a honey colored bile. If it is stagnant for long, you will get a greenish one. Can you see honey colored? Just like honey. So that is a non-infected this thing. I want thermowire. So first I want contrast. Where is the contrast, ma? Okay. So this is the biliary radical. Now take a shoot with cholangiogram. All are wearing aprons. Okay. I want fluoroscopy pedal. Atra illa ideyalla. Okay. So now show the screen. Yes. So this is a grossly dilated biliary tree. Wire is ready. 7 French sheath or 6 French sheath, can you give? ಅಲ್ಲ ಅದು ಲೆಫ್ಟ್ ರೈಟ್ ಲೋಬ್ ತೋರಿಸಿ. Can you see? So that's the obstruction. I'll still distend a little bit so that even after decompression some amount of contrast will be there, easy to see the things. Okay. So gross dilated. Okay. So let us see the needle position now. Okay. Advantage is you can steer wherever you want. See? Okay, now you have to place the sheath. Totally sheath. There won't be any biliary leak into the peritoneum. Between the liver and the skin, biliary tree, there won't be any leak. So that the clean procedure will be there. The post-operative pain also that through the thick Brahma. Show that. So now hilum is preserved. Hilum is preserved. Only there is a CBD obstruction is there. So now we are using a diagnostic catheter to guide this wire through the obstruction, so that once the wire goes beyond the obstruction into the duodenum. माँ आराम है? आराम है? क्या हो रहा है? क्या हो रहा है? Okay. Yeah. Message. So once the wire goes, your catheter should go and then guide it. Okay. Let's see where it's going. Think that's an obstruction. Can be gallbladder. We can confirm that. Remove the wire. Contrast. Can inject little contrast and confirm. Yeah, we are already in the duodenum. That's a beauty. So now see that whatever that fluffy things you are seeing, no, they're all plicae. There are multiple plicae within the duodenum. Give the wire again, thermo wire. Going, that's a path of the wire as well as the catheter you should be knowing. That is our aim. So this is easy to internalize. So once this goes into the duodenum, you can then move around easily. See that papilla it has crossed. Now your aim is to go into jejunum. Jejunum it should go. See, once it goes, so that's how it moves. Yeah. This is the second part is ampulla. Then it's going distally. Okay. So can you show down? Can you show down? I think come to AP. Come to AP. Yeah. Yeah. Somehow it's going down and again it's, you can guide. क्या हुआ? हाँ, पानी पानी. Someone address her requirement. अभी पानी नहीं पी सकता है, थोड़ा थोड़ा देर. ಸ್ಟಿಫ್ ವೈರ್ ಇದೆಯಾ? ಸಿ, so like that it moves. Even the movement, that peristaltic movement will take the wire forward. That is the beauty of small intestine. So now once our catheter, that is the jejunum, that's splenic flexure, whatever. See, that is the ligament of Treats. So that is our location. We can place there. Now we have crossed the obstruction. Now aim is to place our catheter beyond the bridge across the dilated biliary radicals and the duodenum, so that this will keep draining. It has multiple catheter, so not a issue. Now we need a catheter which is long enough. I think ಇದು ಲಾಂಗ್ catheter ಇಲ್ವಾ? ಸ್ಟಿಫ್ದು ಇಲ್ವಾ? ಇಂಟ್ರೊಡ್ಯೂಸರ್ ಇಲ್ವಾ? ಇಲ್ಲ ಇದೆ, ಇಲ್ಲ ಇದೆ. Serial dilatation of the tract has to be done. Then place the long whatever multi-hole catheter inside. Can you show? The problem is exchange length ilva stiff do. Show up, show up. But how to exchange? I want exchange. Kodi. That's okay. ಆಮೇಲೆ ನೋಡೋಣ. Wire will place in the deep into the duodenum, maybe fourth part, so that the wire remains stable, and then we can exchange that with a catheter. See, that is the beauty. The peristalsis will take the wire forward. In fact, that is one of the confirmation that it will be there in the duodenum. Sometimes what happens, if the mass is very friable, that may enter into the peritoneum. So that's why you have to confirm where exactly, because it is a mass, we have crossed. It was very stiff, we crossed it. So now I am going to remove the sheath and do the serial dilatation of the tract. Ideally, which is used to dilate the skin. Skin is the most resistant part of the tissue. It has to be, first we can give a small nick so that the opening part will be easy to this thing. And whereas subcutaneous tissue also you have to dilate, and also the liver capsule. You can see here. Mele torsi. See the direction. So entire tract, if you dilate, it is easy to pass the catheter, multi-hole catheter. Take the next size of the tract. It is same as you do drainage the abscess, no? Using multi-purpose draining catheter. Similarly, you should not lose the access in the meantime. That is the reason. So now there is a wire tip is located in the jejunum, whatever the fourth part of duodenum. You should make sure it's going in the right track. Sometimes near the entry of a capsule, the wire may get kinked. That's the reason we use the stiff wire. Of course, this will support since our catheter is small. This will support. In the sense, in advanced cancer where surgery and all cannot be done for immediate thing, we can do this procedure to reduce the biliary whatever jaundice and enable the patient to get the surgery. Can you show up? See? Okay. That is a little bigger dilator. That is done. Ma dard hai? Nahi na? No pain for the patient. So now this is the multi-wall catheter. You can appreciate. Many holes will be there inside the before the whatever obstruction, and the tip will be there in the duodenum. So now it acts as multi-walls, acts as a bridge, so that the obstruction will be here. It will be bypassed. So internal drainage also will be there, and one more external drainage will be there. Whenever obstruction occurs, you can aspirate, or sometimes it will come out here. Overall, we are reducing the jaundice so that patient will be able to eat normally. Otherwise, she will be suffering from multiple scratches all over this thing, unable to eat. These are the features of jaundice. Jaundice can be infective. This is the case where malignant jaundice, some tumor obstructing the biliary tree. Patient will be very comfortable, done under local anesthesia. Amma, dard hai? Thoda hai. Hath niche rakho. Patient will be able to communicate well without any pain and comfortable this thing, and relieving the major problem of jaundice, enabling the patient liver functions will be back to normal, as well as making a patient fit for the procedure. If at all any major surgery they will be doing. We can see that. ಸ್ವಲ್ಪ ಕೆಳಗೆ ತೋರಿಸಿ. Okay. There is a band. Okay. You can see there is a band. Can you appreciate the band? So the band shows. Can you appreciate the band? I'll pull little. No. Wait. Can you see the band there? Radio opaque band. Okay. That is the radio opaque band. So beyond that, all the walls will be there. So that should be inside the biliary tree. That is the trick here. Otherwise, leakage may occur into the peritoneum. Okay, this should be in the biliary tree. Now, the walls are there before the obstruction and beyond the obstruction, and tip is in the duodenum. Can you show below? Yeah. See? So now we are inside the tip is inside the duodenum. Now I'll remove the entire straightener and everything. You can see here honey colored whatever flow. This is a bile which is flowing outside. So whenever obstruction is there, that will happen. So now we will check by doing cholangiogram what is happening there. Normally, our successful procedure should be good drainage should be there into the. You can appreciate there. There is a flow of bile, whatever contrast into the duodenum. That means, see, can you appreciate that? That means the bypass have been, the obstruction has been bypassed, and few walls are there before and few walls are there after. So that is the thing. So this is a successful biliary whatever drainage, PTBD, percutaneous biliary drainage. Can you see that? Can you show up? Upside? Yes. There is no leakage. You have to make sure that no leakage into the peritoneum. That is very important. You can see the band is there in the biliary tree. Show below. Yeah. So this is successful percutaneous biliary drainage. You can appreciate here a small hole. It will not produce any scar. Amma dard hai? Patient also comfortable. That is a beautiful procedure, and it is a local anesthesia. It will be done under local anesthesia, not even sedation. Patient is comfortable. Small tube is inserted, relieving the jaundice completely for the patient in just 2 days. So, आप दिखाइए जीप दिखाइए. हाँ, okay. ये उंगली दिखाइए. No, you can appreciate a lot of yellowish discoloration. ऐसे दिखाइए हाथ. हाँ. Lot of yellowish discoloration. Everything will be relieved within 2 days. Okay. Suture. Just a small suture will be done to secure this tube. And tube is externally connected to the drainage catheter bag. Sometimes it can drain internally. Sometimes it can drain externally. But our aim is to reduce the jaundice, and later on we can put a stent also to relieve the obstruction permanently. So especially in the malignancy, we put a metallic stent such that no recurrent obstruction will be there. Sac.